announcements before we get going. First of all, our next program is going to be looking at the first 100 days of illness administration in Brazil. So I think we will find that very interesting. And today, also those of you who have not signed up for the newsletter and might like to, there's a place with a pencil up here you can sign up and you can get on our World Concerns newsletter. And I think we're having to do a little adjustment here to get a particular group of pictures that had to be emailed in because the wrong thumb drive came. So we're working on it. It's taking a little bit of time. Let's show a show of hands. Anybody been to Nepal? Israel? Anybody else? Nepal? Okay. Anybody been to another Himalayan country? Another Himalayan country down there? Okay. Well, so we've had some experience like that. How many of you have worked in the Peace Corps or something like that? Good. Look at that. Okay. Let's see. Are we almost there? We're almost there.
And then I'm toying with the idea
And you all know that we are going to take August off. So that's vacation for us. There won't be any programs in August. Okay. And how are they moving? I think we're ready to go. Yes, Grace.
It's my understanding that 2 weeks from today, the contractors are going to be working on the lighting and the sound here. Have they talked to you
Just a
about
minute.
that?
Let's get this.
No, that has not been discussed, Grace.
Is it an issue?
Here,
Do you think they'll be working in the daytime?
Yeah, they will.
So at this time?
So, yes, the AV contractors will be out at the end of the month. They're going to be working on the microphones, calibrating them, and working on Fireside Lounge. But I don't understand the question you're asking.
Will it interfere with this program in 2 weeks?
Is it going to be replayed on HHTV or is it being live?
It was
I
usually
have not been-
in person nowadays.
What I scheduled for the rooms, there was nothing else going on, so it shouldn't.
there's an extra week sometimes in there.
Anne,
Yes.
I was wondering if someone could explain Juneteenth next Monday to me.
Come to the League of Women Voters meeting and we'll talk about it.
Okay.
What?
Maybe we can talk about that later because our guest is ready to go. First of all, we have this guest thanks to Laura Weiss, who came to me and said, I think this would be a good program, and I thought so too. And Laura very graciously started the arrangements with Mary Anne Mercer, and she also is going now to introduce Mary Anne, and they are going to have a moderator-speaker format. So Laura?
Hi, everybody. Thank you for being here. Yes, I read Mary Ann's book in December, and I liked it so much. Through a mutual friend, I contacted Mary Anne and said, gee, I liked your book a lot. And she said, oh, well, I'd like to come and talk at Horizon House. And I explained it. I said, oh, good, we'll see if we could work something out. So here it is today, and we're glad to have Mary Anne, and her photos are going to be rotated around. Some of you may want to change your seats and come over here, but you can decide that later. So here's my introduction of Mary Anne. Mary Anne Mercer grew up in a ranching community in Montana. And though she left home for college at age 18, she still considers herself a Montanan. Her first degree was in nursing, followed later by training as a nurse practitioner. Then came a life-changing event, the opportunity to work in a health project in Asia, specifically rural Nepal. She describes that experience and what she gained from it in her recent book, Beyond the Next Village. On returning from Nepal, Mary Anne pursued a career in global health with graduate degrees from Johns Hopkins and then employment there, traveling for work to many countries in Africa and Asia. In 1995, she decided to marry a Seattleite and moved here, continuing her university work at UW. This book came about after decades of work in global health, recognizing over time the ways that her time living in a rural culture in Nepal had shaped her concerns about the whole culture of health development. So she would like to share some of those insights today. Mary Anne's going to start us off.
Can you hear me? Yes? Thank you so much, Laura, and I really appreciate Anne and Laura. The invitation to be here. I was really excited when I heard it would come through. I was actually supposed to be it last month, and then I had some emergency, so really happy to be here. I'm going to start out by just reading just the prologue to this book, because it kind of sets the scene for the kind of things that I had to deal with when I was there. And then Laura has some questions for me. We're just going to have a conversation about the book and my experience in Nepal and pretty much everything else. So this is 1978 in Gorkha district in Nepal. I reached over to take the wrist of Maya, the young Nepali woman lying on a straw mat on the porch of her thatched roof house. A crowd of family members and neighbors pressed in closely around us, all eyes focused on me. Will she die? Was the unasked question. I was looking at a very sick woman, already in shock. Her pulse was weak, very rapid, a faint tapping against my fingers. Her face had a ghost-like sheen. I reached under her cummerbund to feel her abdomen and found it rigid, board-like. She groaned, opened her eyes briefly with a faintly pleading look, and then closed them again. I murmured softly, "Et dukyo, Reina? Your stomach hurts, doesn't it?" I'm sorry, that was Nepali. She moved her head faintly in response. Maya's husband had confirmed that she was a few weeks pregnant. I tried to imagine a scenario that would end well for this woman and her worried husband, but all that emerged was fear that she would die unless she had surgery very soon. And I didn't put this in the prologue, but my assumption was that she probably had an ectopic pregnancy, where the pregnancy had begun in one of the tubes rather than in where it belonged. I've been in rural Nepal for 6 months, leading a health team, trekking village to village to provide immunizations and a few other health services. By default, I offered simple health care when people came to me with their everyday aches and pains. As a nurse practitioner in the US, I learned the diagnosis and treatment of common illnesses. And I knew which patients needed referral to more specialist care. But the rules from home didn't really apply here, because with no other help available, I found I had no choice but to do whatever was needed, even though that often meant overreaching my training. We were in Gorkha, at a time when the entire district of Gorkha had no internal roads at all. The only way to get Maya to surgical care was a mission hospital that was about 10 hours walk away, up and down mountains. And if the doctor happened to be gone, the trip would be for naught. Was there time to get her there before she succumbed? So I said quietly to the husband, after finishing a cursory exam, "She's very sick." He gave a sideways Nepali nod with a look of grim concern. "K. Garnier," he muttered, as if reluctant to hear the answer. K. Garnier is a city here all over Nepal. What to do? K. Garnier. My clinical mind went back and forth, weighing choices, balancing fear for Maya and reasonable possibilities for action. Was there even a best option? If she stayed home, she would have the care and comfort of those who loved her in her own culture, but with only a small chance that she would survive. How to balance those odds? Finally, I advised her husband that she could be taken to the mission hospital on a stretcher, and it might be possible for her to have an operation that would save her life. He looked back at me blankly, either not understanding or not believing my words, but after consulting with several other men and finding some help, he agreed. After several false starts and delays, Maya was moved onto a stretcher improvised from a heavy blanket suspended between two poles. As the four men carrying her passed out of sight down the trail, I was filled with questions that would haunt me my entire time in Nepal. Had I done the right thing? Would Maya survive the trip? I'd never before had the dilemma of making this kind of decision, weighing odds that had so little basis in medicine and so much to do with poverty and injustice that was everyday life for these rural Nepalis. What was my role here in this world that was so unlike any I'd ever known? So that is kind of the beginning of the book, because it was a moment that I revisited many times with that question: was this the right thing to do? If I knew now what I knew later, this is early during my time in the villages. So Laura has some questions for me.
Okay. Yes, maybe I'll stand up. Mary Anne, what were your motivations for going to Nepal in 1978? What expectations did you have about the work experience?
Well, that's a very valid question, and my answer is pretty simple. Can everybody see me in here okay? Maybe you can move if you can't quite see me, because I feel better sitting. You know, as Laura introduced me, I grew up in a rural area in Montana on a ranch, hadn't really seen the world, and I always wanted to. My mother happened to be somebody who was kind of an armchair traveler. She'd never been anywhere, but she had books about, lectures about what were the famous places in Europe that she would see someday. And I did always have that idea that I would travel. I wanted to travel to Asia. And so I was, I had a clinic in San Francisco. I was a nurse practitioner there. I was the main provider for the patients, and I felt pretty okay about my basic skills, but I wanted to use them elsewhere. So one day, my friend, one of my college friends, comes by my place in San Francisco, and I remember this moment very well. We had dinner together that night. She'd been traveling, and she said, "Mary Anne, if there's one place in the world you should go to travel to," because we were talking about traveling, one place, it's got to be Nepal. She had just come back from Nepal, and she was just overwhelmed with how fascinating the country was, the culture, the conditions that were just, it's going back to another world entirely. So just by chance, it was 3 weeks later, there was an ad in a San Francisco paper that said, "Nurses wanted Nepal." So there I was. It was, you had to admit that felt like fate, right? So very shortly after that, I was landing in Kathmandu. So that was kind of my motivation was, I have to admit, I was terribly naive. I was just it wasn't just an adventure, you know, I wanted to go someplace where I could help people, but I really didn't, I had no idea what I was getting into, no idea at all. So that's kind of how I got started.
And your expectations, what were you thinking would happen to transform you?
You know, they were so vague. I don't think I wanted to help people, you know, I just wanted to help people. And it was interesting because the advertisement for this position, they just said rural area of Nepal, you know, and that's what they said. You know, it's like we're working with immunization. It was an immunization team. Well, I'd done immunizations and, you know, no idea that once I got there was no road, you know, had about a 10-hour trek to get to the office, the field office to begin with. No electricity, no plumbing, no nothing, and every day was trekking anywhere between an hour and up to 8 or 9 hours a day, practically every day for the next year. So, as I say, I was very naive about what I was getting into. I had no idea. No idea.
Right. Well, what you could describe, if you will, your first impressions of Nepal after your arrival in Kathmandu, and then what were your living conditions like then?
Well, yeah, Kathmandu was fascinating. I mean, it was. I mean, I should remember that the road. It's different now. Kathmandu looks different now, but back in '78, '79, driving from the airport to the main part of Kathmandu, you just were in another world. I mean, this was old, very, very old buildings. These buildings are probably been around for 200 or 300 or 400 years, and not everything was like maybe a little bit like in a book of fairy tales. You know, just everything was so. It was colorful, but at the same time very simple. So Kathmandu, the house that we stayed in Kathmandu was palatial. I mean, it was that was a shock as well, because you drive through these streets, you see a lot of people barefoot, wearing, you know, traditional clothes, and kids, you know, playing in the street, kind of, you know, untended or whatever. Our house was a very nice house. It had, you know, it was the kind of place that if you go to work in a lower or middle income country, that's where the expats live. They are always nice houses. They are always, you know, probably 5 times as nice as most of the local people can afford to live in, and that's what we had there. But it was only when I was in Kathmandu, which was only every few months for a couple of days. Going in the rural areas, as I said, the conditions were different. You know, it was basically no amenities. We lived in a tent most of the year. Was in a tent. And when we would go from the field base, you'd be there for a couple of days, get supplies together, etc., and then go out on trek for the next usually 2 weeks. And that was the tent living.
Would you tell us something about the team that you worked with and what you were supposed to accomplish?
Yeah, well, it was an immunization program. This was a time when it was just before smallpox was eradicated. So we gave BCG, which is kind of the thing that is purported to prevent TB, but DPT, the regular childhood immunizations, diphtheria, pertussis, and tetanus, and smallpox vaccines. So we were going village to village giving vaccines. And we had to keep track, of course, because the DPT series requires at least 2, preferably 3, a series to be effective. So that was the job, right? We also did a few other little things like surveys, a survey of, you know, what kind of stool parasites were found. But the big thing was immunizations. What I found after I got there and had not been in practice very long, was that when a foreigner, any foreigner, medical or not, comes to a village area where people really have practically no contact with foreigners, they always assume that you know medicine, that you have medicine, that you know what to do for illnesses. And so the minute we got into a village, people would start coming with their health problems, because there was one hospital in this whole district, well, our side of the district, there were health posts, but the health posts had, were basically unstaffed a lot of the time and without much in the way of medicines or anything else. And we did have a bag with some antibiotics, a few basic medicines that could be used. So a lot of my experience there, and a lot of what I write about in the book, is just having these people come with a medical problem, a health problem, or concern that they've had for a long time and haven't had anybody to talk to about it. They were assuming then that I could take care of them. And because I did, in the U.S., if you're a care provider, I'm sure there's some of you here that are. You do a history and a physical exam. You ask a lot of questions, you try to get a good picture of what the problem is, and then you look at the person and examine, do whatever you need to do to examine it before you try to give a result. I would be sitting like this with a line of 80 people in an afternoon, just waiting to be seen. So that whole system of history, physical assessment, etc., had to be a little bit shortcutted. And a lot of times it was pretty easy to do. It was pretty clear what was going on immediately. Other times, some very serious problems that sometimes I could help and sometimes I couldn't. So it was a combination. We did the immunizations and we did quite well with that. But for me, the challenging part, but also in many ways the more rewarding part was to be able to provide some clinical care for people that just didn't have it. They just didn't have it.
And the team that you worked with included Nepali workers, right? Health workers as well. I've forgotten, were there any other foreign workers beside you?
There was another nurse, Corinne, who became my very dear friend. We each had teams, and we would be on separate teams. In each of our teams, we had 4 porters and 2 other vaccinators, people that would help with the immunizations. The porters were also, one of the porters was also the cook, and I got a picture in here somewhere of my team, and I loved my team. The porters themselves were basically uneducated Nepalis, very strong, and just sort of a wonderful entree into the culture, because at night we had nothing to do but sit around and talk and just kind of find out what was going on in their lives, and it was quite interesting. So I had Corinne was there as a friend that we usually met up every couple of months, but we actually sent a lot of letters back and forth, because you kind of, after a while, it wasn't just, there were 2 things. One is that I would be, part of the time I'd have somebody who spoke English on the team. We had an extra person who they called an advance man, and he would go to the village ahead of us to get permission for us to come and all that. And this would be a Nepali who spoke English. And so that was great. I'd have someone else to help with it takes a while to learn a language that is completely different from English. There's basically no words, there's no cognates at all. So it was nice to have someone to speak English, but then also to help me with translations when something was difficult. But that was my team, and I'm gonna, somewhere here, I have a picture of my team. Anybody recognize this picture? The very little one in kind of the middle, slightly to the right, in the middle of the background. Just this little guy up here. It's Mount Everest. Mount Everest is not a Orca district. This was a trek that I took when I was having a vacation. I'm showing these pictures here just as kind of background to give you some picture of some idea of what things look like and what the people looked like, what kinds of things I came across. So for example, this is the kind of thing I would see. This is a young girl who was, I think she might have been 10 or 11, very small for her age. And she had a heart murmur that I could hear from here to there. She had a very bad heart murmur. That's why she was so small. She could hardly play. She would have to stop and, she was alive, she was alive and she was functioning, but really, really, had a very bad cardiac defect, and there was absolutely nothing I could suggest, because at that point in time they weren't doing, even if we had been able to get her in Kathmandu, to Kathmandu, they weren't doing those kind of surgeries. So this was one of the difficult things for me, was coming across things like this there was nothing I could even suggest. It was absolutely nothing besides, sorry, your little girl was, having these problems. Yeah, I'll just, since I'm coming up with these pictures, I'll just let you know. Anybody have any? This is an older man who is, he was telling me he's got this back problem. He's had it for years and years, but he just wonders if anything I can do for it. And I think we've got somebody here who might know what it was. I don't see him. I'm sure he had tuberculosis in the spine. There was a lot of TB out there. He had this forever, and he was living with it, but it was uncomfortable, and it seemed to be getting worse. So the tuberculosis kind of affects the bone and makes it what you have here. So these kind of problems, and there was nothing I could offer for that. Even if he, if it was active TB, they were doing some kind of simple treatment, but it certainly wasn't going to solve this problem. Anyway.
We've talked a little bit about this. Yes, I need the mic.
What were the main challenges of the work? You've talked about some of them, the language barrier, a little bit about physical challenges, because you sometimes had to trek a lot of hours to get to the villages and then come back. What did you see as the main challenges that you were facing?
Well, and there were many different kinds of challenges, right? Certainly physically, I had no problem living in a tent. I ended up loving the food. We had the same, basically, dal bhat, rice and all lentils twice a day, and it was good. There was no problem with that. But the trekking took a while. I wasn't totally born how much of these are mountains, right? These are what certainly in the U.S. we would call mountains. They would be up and down for, as I said, for anywhere from an hour, if it's just a short trip, to 8 or 10 hours. I wasn't warned. My idea of getting ready for this, I knew I'd be walking some, so I would go running, and I was living in San Francisco in Golden Gate Park, which is pretty level. It didn't really help much at all. So that was a big challenge. But it took, after I had gotten through the first, probably it was 2 or 3 months before I was really okay with it, but I was fine. I was in good enough shape that it was not that much of a challenge. I think, personally, the biggest challenge, even bigger than that, was that I was looked at all the time. Day and night. The only time I got away from being looked at, I have a picture somewhere in here I'm in my tent, and it's hot, right? So you have to have the screen thing open at the sides, so I get air in, and it's filled with people. They're just looking, mostly kids, but even adults would do it, because I was, it's understandable. They don't see foreign people coming, but it was, I'm basically pretty introverted and need time alone, and there was no time alone. That was hard. That was probably the biggest challenge of all. But even that I eventually got used to, because you think, of course they're interested. You can't blame them for being interested in what this strange-looking person. One woman I remember got up close and she said, "I've never seen blue eyes before." It was just an interesting thing. The other, of course, big challenge that I talked about is just trying to so Nepal at that point in time, and still pretty close to being one of the poorest countries in Asia. Rural areas, poorer than the urban areas. So here's this poverty that I'm constantly surrounded by. Getting to be very close to my team, I had these two vaccinators. One of them, there'll be a picture on here somewhere of Sita, and I read about Sita in the book because she was a Nepali woman for me, you know, and a kind of a remarkable person. And as well as the others, the porters, etc. What was hard was realizing, and I wrote this, I think I put it somewhere in the book, this idea that if something bad happened to me, you know, we were trekking on trails that were a little bit difficult sometimes. If I'd fallen off, actually we had a reporter that did fall off once off a fairly steep thing, he was okay. But if I'd fallen off and gotten injured, they would have gotten word to headquarters, and I would have been, you know, helicoptered back to Kathmandu and then probably on to Bangkok or someplace for care. That's because I was a foreigner. Here I was working with these women that I loved. I mean, it was very much, I really felt very much like this was my family for a year. And if something like that happened to them, they were toast. I mean, they were toast. There was no, I mean, this inequality was just so in my face. I mean, it was so in my face all the time that was also a big challenge. And dealing with the effects of the inequality, which was health problems and lack of health care and all that.
You began by telling the story of the woman who you thought had an ectopic pregnancy. You want to tell us how that story ended, or do we have to read the book to find out?
Well, it did not end well. I mean, it was two interesting, two parts of the ending. One was that, you know, after I think it was a couple of hours after they, you know, the guy got some people to help him, and they went off to try to get to the mission hospital. And then we got a message that she had died. Well, that was one thing. But the other thing that was interesting about that situation is that before the team even left, there was like this gap between. So I'm saying, okay, I think she's, you know, I think she will probably not live if she doesn't have care. And here's where you can maybe care. You know, it was a hard decision to even suggest that go there. Well, finally they left. There was a delay, and finally they left. And then Sita said, Sita was the vaccinator that really was my cultural ambassador, kind of. She told me what was going on, you know, and she didn't speak English, but she got my Nepali at first well enough that, you know, we could communicate. She said, they don't think that it's what you think it is, this problem. They think, they being the neighbors, probably the husband, everybody, and they think there's been a spell. They think that one of the neighbors is jealous and angry, and it's a spell, and that's why she's dying. That it's not something that the medicine can cure. And this was, you know, this was something that it took me the longest time to get this in my head, that my ideas about a medical problem, and I was, you know, there were not a lot of things that were completely mysterious. I mean, there were tropical diseases I didn't know, but most of them were pretty basic stuff that I managed before, in the clinic in San Francisco. Many times, what looked like a basic medical problem was something else. It might sometimes due to you know, just, for example, some people would say, oh, I drank too much cold water, and so I got cough the next day or something. You know, traditional beliefs about what might cause an illness, but so often it was spirits. So I had a little girl who was, she had gotten her first DPT shot, and we were back in the village for the second one, you know, a few weeks later, and I went to the families, I went to the house to say, you know, your little girl we're trying to get her second one so she'll be better, you know, prepared against these diseases. And the father says, no, she can't come. And I said, but, you know, she has, what did he say? He didn't explain why exactly she was sick. He didn't explain what was the sickness, and then the way they described it, it sounded like she had a fever, that she had a fever the day before. I said, but no fever now, we have some medicine we can give her so she doesn't get a fever with the DPT, you know, just trying to do the usual things. And he said, no, it's not a disease. You know, she fell down and kind of she fell down. I don't remember exactly how I described it, but basically it sounded like she had a seizure. Probably a febrile seizure. She had a fever, and then she, you know, got hot on the way down. And of course, so I said, oh, so we'll have to, you know, I was going to try to help with explaining that. But they're doing a puja. They knew what they had to do. There was a spirit that had caused this, and so they had to do a special set of prayers. They were getting ready to do these prayers, and that was, you can't have medicine while you're doing these prayers. And it was like over and over again, I would come across these situations, I go, think about it. What do they think is wrong? What is their perception of the problem? Because if you can't address that, you're not going to convince anybody to do anything. We had pretty good luck with our DPT vaccinations, which in itself is kind of interesting because they didn't really know diphtheria. They knew pertussis, which is, I mean, they've had examples. I had an example of a man who said his daughter had died, you know, a few days after giving birth, and I said, what do you think? How did she die? What happened? And he goes like this. And that is the sign of someone who has tetanus, and they have, you know, it's the disease. It's the lockjaw. And so they just go into muscles go into a spasm, and then we eventually die. So I knew there was tetanus around, and I knew that the vaccine was some good, but it's not a very common problem. So all these things we were immunizing against, the people didn't really understand that they were big problems for their kids or for the mothers, because we did give women diphtheria and tetanus shots too, because of that problem of maternal tetanus and tetanus in the infant then. So anyway, there, you know, it just, the longer I was there, I mean, at first I thought I was figuring things out, and the longer I was there, the more I realized that there was really a lot of stuff that I was missing and that I needed to learn. So that was kind of.
Well, that really, I was going to say that really goes into my next question, which is how did your views about Nepal change over time?
Yeah, well, as I say, it did change a lot. I mean, it was just an incredibly expanding experience for my mind, and it's how I ended up staying. I mean, I've continued to work in this field ever since I came back from Nepal, because it was just such a, you know, it taught me so much. Just 1 year, I felt like my head was full of things that we needed to know in order to be of any kind of use at all, in terms of providing, you know, aid, the aid world of aid to the poor countries. So I learned a ton about, you know, just the kind of the deeper reasons for all the problems that they had. I mean, clearly poverty was at the basis of so much of it. And I mean, I think the two things I learned were, one was I felt at home, you know, after several months there, I felt at home, you know. I felt like this was a community very much like the community that I'd grown up in rural Montana, in that people knew what other people were doing, and by vaccinators several times, you know, there were things that would come up and they said, you know, I mean, here's an example. The part that I had real problems with in Nepal was caste, the caste system. Caste system where you are born into a category that cannot be changed, and that puts you very, very clearly in a hierarchy to the untouchable caste, which are the, you know, absolute. They're not even in the caste system. They're so low. They're out of the caste system. So that was a part of Nepal that I really had a hard time with, because I had to deal with it. So, for example, one time we had a helper. Every time we go to a village, we get someone who would be really good and help us. And this one man was the town crier. You remember our town criers in the fairy tales? Somebody who stands up and, you know, shouts out to the village. Every village had a town crier. And this guy it was just great. He would find this tall place to stand up and just shout out everywhere. And tomorrow, tomorrow afternoon, come to this particular place for all the well children for their immunizations. So he did this, and we wanted to, at the end of our time there, we did really well. We had a lot of kids come in. Fine, we're going to do a little kind of a celebratory dinner, which we would do, and so I was talking to Sita about it, and I said, so we can all, there was one little place in one of the meeting hall that we could eat, and she said, oh, but we can't because he wasn't untouchable. And she said, if my parents found out that I had a meal in the same room, a same meal with an untouchable, I would have to quit immediately. They would know the next day, and I would be done with this job. So it was, those kind of challenges with caste were really difficult, and I, it's of course not for there I consider it a black or white thing, but then the idea is, Sita, in fact, this was Sita who said, I was talking about caste, and they knew how I felt about it, and she said, but don't you have problems like that with black people in America? Going, yeah, well, you had to admit that this is not a unique problem. It's a very specific problem, but, in some ways, if you're black in America, you don't change that. There are certain stresses on your life that never go away. So, still, caste was a problem. The other part of that I struggled with during my time there was the status of women. So if you can imagine, you sort of know that there are many places like the U.S. where women don't have as lower status than many men, and other countries where it's more marked. But in Nepal, here's how clear the status of women is. There's a tradition in Nepal. It's called juto. You may have heard of juto. Juto means when you have something in your mouth. If you start to eat something. It doesn't actually apply necessarily for children, but the mouth is contaminated. Basically, it's contaminated. You simply can't. You would never, for example, eat from a common. You would never eat from a common bowl. Like in some countries in Africa, you just do this. You would never do that because your juto would be contaminating this food. In Nepal, when man and wife marry, they have a beautiful, wonderful wedding ceremony. The wife has to eat the husband's juto. In other words, he gets some rice, puts some rice in his mouth, and feeds it to her. So it's just showing her subservience. It's just, to me, it was just a perfect example of touching the feet. The wife touches the husband's feet every day, every night at bedtime. And that's, again, touching the feet is not right. It's just those things I had a hard time with, I have to admit, and again, status of women everywhere is a big problem, but it was so in my face, that was a hard part. So those were some of the views that I had and struggled with. And is it time now?
Yeah, I'm just thinking it may be time to start the questions. I had wanted to have you expand a little bit more on some of your other experiences, but that could probably come out with the questions.
I would like the mic runners now, please. You're here, and we have a mic runner over there. Do we have a mic runner over there? Okay. Yeah. Would you go, Grace? Okay, you take that part of the room.
Do we need to turn this off when they're not so we can?
Well, experiment.
Depends on the battery.
Okay, you do that part. Do that. Hands up. Question?
So, Mary Anne, as you spoke, I was so struck with, even though there's much even in our U.S. medical system that seems mysterious to all of us, nevertheless, it's very ground it in empirical science, counting, weighing things, learning that certain drugs are effective against certain diseases and so on. And
What's
we
your
didn't
question?
have much of that. So I'm wondering if you noticed an increase in, like, I don't know, being aware of your own kind of intuition about what was going on, and if you could speak to that a little bit.
You don't know with the patients that came to me, people that came to me? Do you mean people that came to see me for their illness?
Yes.
Yeah, yeah. It wasn't so much intuition, because I think for me, I think my intuition is, to a certain extent, based on the culture that I come from. But I really did, over time, slowly, it took me a long time. I just thought, how can I not figure this out? But slowly try to listen and then talk to Sita. You know, what do you think? What do you think is going on? Do you think, is this, whatever? Because they would be, sometimes they were simple medical problems, and other times they were, they would use a term that I thought, what does that mean? And they would say what it means, and it didn't make any sense to me. So it was definitely a process of, it was a process of finding out way more than I would have to find out when I was doing medical care in this country. Yeah, for sure.
Dorothy,
Just opposite.
How did you stay healthy? For example, did you go in a room where women had TB?
Yeah, that's a good question, because TB is, it is a very infectious condition. I didn't spend a lot of time inside. That's kind of the simplest answer. Once in a while, we would go to someone's house for a meal. Sometimes we would sit in one of the like the school teachers. School teachers often spoke English, and they were really happy to have someone to speak English with, and so we'd eat there. But most of the time, we ate out. We had kind of a large room, or even outside. We would be sitting outside, and didn't really have, certainly in sick people, that could have been the exposure, but even that was outside, and as you probably know from COVID, it's not 100% safe, but it's certainly safer to be with someone who has an infectious condition outside. So, it's interesting, I worked with TB patients after I left Nepal. I worked with TB patients in Cambodia refugee camps, and I'm sure I had TB patients there, well, I know I did, but I never got positive for TB, so I guess I was either lucky or, maybe I was careful enough.
Was it cold to eat outside?
No, the weather was most of the time, the only problem with weather we had was rain. Because when the rainy season started, many of the groups would stop working during the rainy season, but we really had to continue. So then we would have to find a place that had a roof and not a leaky roof, which was the biggest problem. So, but yeah, no, it was the temperature was actually pretty nice. It was pretty nice. It was very hot for a while when I first got there, but then it cooled off, and good weather for trekking.
question back there?
What organization were you working with?
Yeah, the name of the organization was the Tom Dooley Foundation. And Tom Dooley was a guy from way back in the 50s, I think, who had lived in Asia. I think it was former military, and he died fairly young. But the foundation was named after him, and the Dooley Foundation had been working in Nepal for quite a long time before I started work there. And it turned out to be a pretty good NGO, non-profit group. They were doing some good work that we, tried to do anyway.
Oh, here.
What were the mechanisms for sanitation in the communities? In other words, where did they get their water? How did they drink it? Where did they dispose of their waste, etc.?
Yeah, so water, usually, there were some areas where there had been some, quote, development, where they had actually had some kind of a well, but typically, most of the places where I went, the water, they either took water from a stream, there were definitely places where, I don't know how to explain it, but like in Gorka, the town, when I was there, we would get water from, it was a spring, I guess springs is what you call it. They did have springs around different places, the mountainous area. So the water sources were varied. I'm sure some were very contaminated. Others seemed to be, coming from a fairly, inside the mountain, fairly good. There was basically no, we just boiled our water for drinking. I did, and I think none of the other in my team did. In terms of defecation, you go to the trees. You just go somewhere. It's all outdoors. Very, very few outhouses in Nepal. It was a huge push. Some years ago, the USA just did this massive push to try to get people to have outhouses and have simple ones that could be simply built, for not much money. But it's been, I think, somewhat successful. But that's one of the reasons why their water is so bad, is that, if you have something and you put right next to the stream and it's a convenient place to go, and it goes right in the water and keeps going around.
This is not a Nepal question. You also, after you got back, you went into Asia, and other parts of Asia, and into Africa. Where are some of the places you went, and how did you compare those experiences with Nepal?
Yeah, that's a good question. I mean, what was interesting to me was, to me this was just this is what I went through, and I didn't. All I knew was what I knew, because I knew nothing about international public health. Total blank slate, right? So I learned a ton about this particular setting, and I thought, well, I'm not sure where I'm going to be able to use that because, it's only one little country. But it did turn out to be extremely useful for the rest of my career, because what I had learned in Nepal was listen to people, find out what's really going on. And that, I have to admit, is one of the things that just isn't always done in all of these big international development programs that we have. There's so many times we know what people need to do. So what do? We educate them. I mean, the example, so many examples about what that, this has been several decades later. I've seen lots and lots of programs and examples of what were they thinking? What were they thinking? A couple of examples. This was a program, when I finished my studies at Hopkins, I took over a program that was in charge with basically trying to work on prevention of AIDS in Africa. Way too late. I mean, there was already a lot of AIDS in Africa, but that was it was going to be working. I was working to provide training and support to US-based groups like Save the Children, World Vision, some of these groups that had done a lot of other health programs but had not ever worked with HIV, because this was pretty early on. This was in late 80s. So I started working with these groups and found out very soon, very quickly, that they didn't get this idea that HIV is not like childhood diarrhea or malaria. There's something very different about this problem, and you've got to understand what it is. So I had a workshop where this group of, there were 7 NGOs, 7 groups with 10 or 11 different projects. We had a workshop. We had an anthropologist from Zimbabwe, a Zimbabwean woman, who came to the workshop, and she explained about HIV in Zimbabwe and how it just wasn't at all what we thought HIV was. And again, if we don't know what the population thinks about something, how on earth are you going to have a program that is going to be effective in helping them, avoid it? So here's her example. In many parts of Zimbabwe, she said, people think that AIDS is Renyoka. Renyoka is a traditional disease. It's a traditional disease in Zimbabwe that is caused when a married man, has relationships, has sex outside his marriage. Okay, well, you can sort of see the connection there. But the thing that's different about Ranyoka from AIDS is that if a man can get sick, and they call it this wasting disease, he can get sick and die from it. He will get skinny and die. The woman from outside his marriage may also, but the wife is safe. Not the right message, right? Or not the right message that if people believe that, how, your message is just going to be nonsense. I mean, nobody's going to really understand. What are you talking about? Why should I protect my children against AIDS when I'm not being unfaithful? It's the bad people that got it. So those kind of things, and these nonprofit groups, all of them, were setting about. It was early in their projects, and they were going to do a survey, and they were going to ask people what they thought. And just question and answer. What do you think? A, B, C, D, which of these things? What is causes of AIDS? All this stuff. And from that, they were going to do their programs. Well, they were very clearly going to get all through this baseline information and not have a clue what people really thought about AIDS. Because they weren't listening, they weren't talking to people and hearing what they had to say. It was kind of early because it was interesting because this is the time there's a process called focus group discussions. You've probably heard of. It's a very specific way of putting people together and trying to get information from a community. And these groups had never, it was early on, they hadn't actually learned focus group discussions yet. It became the thing much later on. But we did some practice focus group discussions, and it was like, wow, we don't have to do a survey, we can get information another way. They eventually did some pretty good work in their AIDS prevention work, but it was just an example of how if you know what you think you know what you're doing without asking the right questions, it's just not it's not going to work.
Any other questions over there?
I understand there are beautiful birds there. What can you say about the natural beauty, waterfalls and so forth in Nepal?
Yeah, I wish I had known more about the wildlife. My memory of the beauty in Nepal was not only the villages, the people. I mean, they're beautiful people. They're just beautiful people, and they're always smiling. And it was a fabulous, just a community you put down in. But in terms, and I didn't know the birds. We heard birds a lot. It was butterflies. There were butterflies everywhere. We would be walking down a little, beautiful little trail, and with these little, just through a quaint little village, and butterflies following us all the way. It was really quite amazing. And the Nepalis love flowers. When they would have, they had, whenever the very poorest people didn't have the time, energy, anything else for it, but many of the village houses, especially sort of the middle of the village, had beautiful flowers around their houses, and we actually had the house when I was in the house in the Gorka village, which is where our main office was in the district. We had some roses along the side of the path. They got plucked all the time by passers-by because they loved flowers and they needed them, for they used flowers for a lot of their worship, their worship ceremonies, the Hindu rituals.
There must be something to do.
You're on.
That's fine.
That's on.
There must be something about doctors and going to other countries. My neighbor across the street, Roger Rosenblatt, who taught at the University of Washington, was a doctor, and he and his wife traveled in China and up toward Mount Everest, and they traveled all over, and then some people here, Jane Hastings, I think, went on one of the big hikes up into the mountains there
Do you
in
have a
that
question?
area too.
Eduardo,
Well, I was wondering whether, if the type of conversations is just really prevalent at the University of Washington Medical School or something, because it seems like so many of the doctors have been there.
I was talking earlier to, I think, Laura, about the idea, when I came back from Nepal and did my studies and I started working in this field, it was kind of, it wasn't very widely, I don't know, the word wasn't I didn't know a lot of other people that were doing it. But even since I've come here, so I came to UW in '95, the field of global health is just expanded. Most of the medical students seem to want to do something in global health. We have a big Master Public Health program in the Department of Global Health. It's just, and I don't, I'm not totally sure exactly. First of all, I'm not totally sure if it's a good thing or not. It probably is, but not necessarily a good thing. If the idea of global health is to go someplace and give out pills and go home, it's just not the kind of thing that's really going to be helpful. And unfortunately, a lot of programs are kind of like that. They don't think about what's going to happen in the future. You might have a few $1,000s to go do this little program, and then you leave, and then what? We have a guy at UW that did a lot of work on camps. There would be eye camps, which I think generally are pretty good, but there'd be other health camps where doctors come in and they're just there for a week or 2 weeks, and they do what they can do, and then they leave. And I know I think many of those kinds of approaches are of questionable value. So yeah, there's a lot of interest in global health now, and I think most of it's probably good.
Grace?
I'm curious to know whether you learned about local treatments other than getting rid of this bad spirits that actually work.
Yeah, good question. I didn't learn much. I didn't learn much about it. I actually learned a lot more about traditional treatments and what they did and how they worked when I left Nepal, and I spent 6 months working in a Cambodian refugee camp. The camp had 3 major buildings that were medical buildings. One was the TB ward, or the TB building where I worked. Another one was general medicine, but the other one was a traditional medicine center. It was a massive, massive tent with about, must have been, 6 or 8 different little sub-areas where the Cambodians could come for whatever their problem was. They were, it was a massage center, there was a lot of skin disease, skin problem center, they used different methods. There was also definitely a priest who was, for people that had really emotional problems. Can't remember the other ones, but it was really interesting, and I remember thinking at the time, it's too bad I didn't know more about this in Nepal. I had one experience with, only really one. It's funny because you kind of I wanted to know more about what particularly they call them Domijakris. They're healers, and they sometimes use physical things, but they often do bring in the spiritual causes. And it was very interesting. One of our porters ended up with had a terrible, he had migraine headaches. He just had this terrible headache, and so the local people called in their local doctor. His name was Prem, the patient, and he said, "Pimsop, could I have, after the treatment was over, could I have some aspirin too?" And who knows which helped, but migraines, they're hard to deal with.
Is there any other questions? You got to wait for Mike.
As Belgians sound pretty isolated from the rest of the world. I'm just wondering, obviously contagious diseases can travel around the world and so forth, but things like, let's say, the looming debt crisis in this country that could affect your world, do they generally get affected by other world problems, or are they so isolated that their lives just go on as they have for thousands of years?
Oh, that's an interesting question, because one of the things that I've been sort of working on, concerned about the last few years has been debt of developing countries. And if you look at, so the poor countries of the world, some years ago, 5 or so years ago, there's a lot of them, they were really pressured to borrow money from the International Monetary Fund, and so they ended up in debt, and then came the pandemic and came, just disaster for these countries. I think I looked up what the number, I think it's like $6 billion that the developing countries owe in debt. And it's kind of, it makes me think it's kind of like the new version of colonialism. You know, we used to go out there and own the countries and be in charge, and now all we do is take charge of their economies. And so that they have, so Nepal has got huge debt. It's got a huge debt, and Nepal, which has never been colonized, but it still has, they're part of this system that says, oh, you want to do all these good things, borrow some money for it, you know, and it's at very low interest rates before. Then the interest rates go up, and it's really a problem. So I would say Nepal as a country is part of that whole system. I mean, it's part of that whole, I hate to call it some bad word, but really it is something that makes developing countries very dependent on us. And we have not been terribly responsive to seeing what really is going on there.
I have a question for you, and that is, tell us about what that illustration is on the blackboard.
Maybe I could show a few more pictures just for fun. So this is one of our volunteers. He was an airline volunteer he came out for a couple of weeks, and that's one of my advanced men, Captain Limbu. They were doing.
Use the mic.
Oh, I'm sorry. A volunteer and Captain Limbu, one of our advanced men. They were doing education, health education for these kids, trying to explain about worms. So here we have, this kid is standing here, look at his feet, and this little worm is getting into his feet, and also he can get it by eating. You know, so it's worms, you know, parasites were a big problem. They particularly there's one kind that really causes anemia, so people will be very, very anemic, but there are others that just give you GI problems. I was proud to say I had two parasites while I was there. The Nepalis said, "Oh, you're just like us." It wasn't a big problem for me, but it is certainly for children. So that's our health education.
Wait a minute, the mic.
The same picture.
Okay.
I was looking at, wondering, I noticed there's not a single girl there. Is that typical?
If there were girls there, they would be at the back. Because, you know, women don't get to be in front, they're in the background. That would be, I don't remember, we definitely did have girls, but they were usually pretty little. Once they got a little bit older, they kind of knew their place a little better than honest to not. This is Bimraj, our cook, cooking what is absolutely the standard meal. It's, he does have a vegetable there. He had some spinach in with the dal bhat.
I was going to ask, what other kinds of things did they flavor the dal with? I assume it's whatever they could get on hand.
Yeah, they grew things. They grew, you know, several of the basic spices that they use for the Nepali food. And I don't even know exactly what they were. I mean, I would be guessing if I tried to guess, but I know there would be fields and somebody would say, oh, that's, I don't remember which one, but a spice of some kind that they would grow with their food.
But vegetables or?
Yeah, I mean, they would have, it's not big on vegetables, but a standard dal bhat meal would have something on the side as a vegetable. It could be potatoes, or it could be, you know, spinach in this case. And they had things like squash and a number of different things. Mm-hmm. And they would try to have vegetable for when we were, you know, trekking in the field. Once we got really far out of the town of Gorkha, my last trek was way up in the mountains, and they ran out. There was no vegetable. It was just rice and dal. You know, we left with it.
Any other questions? Comments? Oh, one down here front.
This is just curiosity. Having lived in Montana for a time, your ranch is near what town?
It's far east, north of Glendive.
Okay.
Yeah, almost. Our land actually bordered on the North Dakota border. Yeah. This is an example of when we went to the far north area. These were you can look at her foot. She fell on one of the trails, and I had put a cast on it, just so she wouldn't have to work on it. But there was no options to getting home. I mean, she had to still continue to walk on it. But most of the trails were much more easily accessible than this, but this one was a little tricky.
Any other questions? Oh, over here?
Oh, just a comment. After Lynn and I got engaged, I left for 11 months to do some volunteer work, and part of that was with an agricultural missionary in Assam, India. And the people tried to be accommodating to us, of course, and so forth. There were 3 of us guys plus a missionary. And we went to one village where they had constructed a latrine for us. They knew we used latrines. And they built it upstream, out over the water. So it would be, a little marvelous experience. Totally wonderful and inspired that to do that. And we were introducing a plow, a moldboard plow, which would turn the soil over. And we were using DDT, they were agreeing with that, and we tried to introduce the idea of borehole latrines and demonstrated that. 2 of the 3 caught on. The borehole latrine didn't go.
Borehole latrine or more? No,
just digging a hole for a latrine. They didn't pick up on that.
Yeah, for sure.
Anything else?
I just want to show you this picture. So this woman is spinning some cotton. See the cotton? No, I can't see it. There's her yarn over there. But this is cotton they grew. Cotton that she would spin, pluck it, spin it into this. And she had I have another picture. She's working on a loom, making the cloth. And her husband, the picture in this, another picture, her husband is wearing a shirt that she made out of the cloth. It was just amazing. It kind of just full circle on talk about sustainability, right? You've got your little cotton field, and that's what does it. We may be looping around here. This is kind of what the immunization day would look like. Those little tins would hold the needles, and we had alcohol and cotton balls, and just people would come and we would do it.
You mentioned in your book, another group had come in and used brown needles that did not turn out well, and so you came along with needles that weren't brown, but nobody wanted your shots. You want to explain it?
So yeah, that was one of the many things we learned about, trying to make sure that everybody, if you're going to help people, make sure they understand as much as possible about what you're doing. So for example, kids after DBT, right, often will get a little fever. So we said, you may have a fever, and if you have a fever, here's this medicine. We'd give them some tablets. We give them a proper dose of most of this equivalent of Tylenol, for the next day. You could give them that for the fever, make them feel better, bring the fever down, etc. But this was something else. And this was when we were doing the BCG vaccine, which goes into the skin. It's intradermal. It doesn't go into the muscle. It goes just a tiny little prick on the skin. Oh, sorry. So we used because we have lots and lots of kids, and we used different needles basically for everything. But with BCG, because it was so, depends on when we ran out, but we would use separate needles for the shots. But the kids the previous program, there had been a Japanese program that came through, and they were doing BCG for the whole district and doing probably a pretty good job of it. But boy, did we end up, two different big problems with that. One was the black needle, because they would put their needle into the flame and it would come out black, from the soot. And so the people would be watching that and the story that went around, they would watch what we did. And I think that we probably did use that way of doing it, but it was always never with a black needle. You know, you don't have to make it, you don't have to sit on it. If a child had the shot with the black needle, they're going to be sterile when they grow up. That was the rumor, and everybody knew that. It was a big, big problem. And so we had to be very clear that we weren't using a black needle. But it didn't really, I mean, they were, obviously, you could imagine in a country where family is everything, that the idea that child would be sterilized was just really, it was the worst possible thing. The other thing that happened around BCG was that in one area, this is pretty far away from main populations, we walked into this area and sitting down, just talking to people, we're getting ready to do our vaccine thing, and they said, "What are you here for?" And we said, we're a vaccine program, we're going to do immunism tomorrow morning, we start, blah blah blah. Turned around and they were gone. There was like 4 or 5 women sitting there. I remember it so well. I was like, what happened? They're out the door. I mean, we were inside, we were sitting on some rocks, but what had happened, we found the story later, what had happened was that probably the same vaccine, BCG vaccine team had come in, and the kids, what happens after the BCG shot is that they get a little scab on it, it gets a little sore on it, and it takes several weeks for the sore to go away. That's just how it works. And so every time we did BCG, we say, "Haksha, da 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 da," a little saying about, "Don't worry, it's going to have a sore," etc. These people maybe didn't have that, we don't know. But what happened was, around the time they got the BCG vaccine, and all these kids had BCG, they had a terrible outbreak of measles. Measles, which is the biggest, as far as an infectious disease, that's what kills kids. So a whole bunch of the kids died from measles. And they're very vulnerable to it because they're malnourished to begin with, and so they blamed it on the vaccine, of course. I mean, what else would you, be logical, it looked very clearly like that's what it was. So anyway, that was, that's just one of those examples of what not to do when you're trying to help people.
Matt?
You really struck a chord when you mentioned being stared at. I happened to have the opportunity to be an exchange student at a smaller town in India at the university. Lived in a dorm room, the guest room, with a fan and our own bathroom.
Oh yeah.
Yeah. But the minute I stepped on campus, every eye never wavered. And I remember my roommate, my American roommate, was a Fulbright scholar. And I remember going home one day and throwing my books on the bed and just being so tired of being gawked at. And she said, "Oh, just think, Madge, 100 years from now we'll all be dead." She always had the right quip to make things okay.
I think not everybody has that same feeling. But when I hear about celebrities today that are just altering, I am sympathetic. I get it. Truly get it.
Do we have any other questions for Bud Dunn? I think we need to give a real vote of thanks for having Mary Anne come and talk to us. And she does have a book up here, it's just $10. If you're interested, it is absolutely fascinating reading. I've read the book, and it is truly fascinating.
My pitch for the book is she's selling it for rock bottom price of $10. I paid $16.95 plus tax at the
It's fun to make it simple,
I don't know if you can take cards though.
No, I can't take
No,
cards.
it's cash or check. Okay, thank you all. We'll see you next time with Brazil and what Lula has done in the first 100 days of his administration.